Hello everyone. In this video, we will be discussing postpartum hemorrhage, a key topic in the NMC OSCE exam. But before we dive into the station itself, let's first understand what PPH means. PPH is a serious medical emergency and it remains one of the leading causes of maternal morbidity and mortality worldwide. We can define as the total blood loss of over 1,000 after a cesarean section or between 500 to 1,000 ml after a vaginal birth. And this is usually accompanied by signs of hypovolemia. It can occur within the first 24 hours of delivery and even up to 12 weeks postpartum. Okay, PPH is divided into two main types. We have the primary PPH, which is a blood loss of 500 ml or more within the first 24 hours of the birth. And this can be classified as minor, which can be a blood loss between 500 to 1,000 ml, or major, a blood loss exceeding 1,000 ml. Or we can say secondary, which is defined as a heavy or abnormal vaginal bleeding that occurs between 24 hours and 12 weeks after birth. Okay, next let's look at the causes of postpartum hemorrhage. Which can be remembered as the four T's: tone, tissue, trauma, and thrombin. Moving on to tone, we have the uterine atony, refers to the failure of the myometrium to contract, preventing effective compression of uterine blood vessels and leading to continued blood loss. Multiple factors contribute to uterine atony. Some include, but are not limited to, overdistension of the uterus from multiple gestation pregnancy, polyhydramnios, or uterine muscle fatigue from prolonged, difficult, or rapid labor, and bladder distension from a full bladder, or the use of uterine relaxant like nifedipine, magnesium sulfate, etc. All this can lead to the uterus not contracting effectively, therefore leading to PPH. And this can be seen in the image below the video. Moving on to tissue, postpartum hemorrhage can occur when parts of the placenta or amniotic membranes are not completely removed after birth. This can be referred to as the retained product of conception. Retained tissue inside the uterus can prevent it from contracting properly, which results in ongoing bleeding. Another cause is abnormal placental attachment, such as placenta accreta, where the placenta grows too deeply into the uterine wall. This makes it difficult for the placenta to separate naturally after birth, increasing the risk of severe bleeding. Also, pulling on the umbilical cord too forcefully or too early, known as the excessive umbilical cord traction, can lead to complications like uterine inversion or a retained placenta, both of which can cause PPH by interrupting the normal process of the third stage of labor. And this can be seen in the image below the video. Now we have the third T, trauma. Genital tract laceration or trauma to the genital tract can cause PPH. During vaginal birth, laceration of the cervix, vagina, and perineum may lead to significant hemorrhage. Operative vaginal deliveries utilizing forceps or vacuum, use of episiotomy, and occurrence of uterine inversion can increase the patient's risk of trauma-related PPH. Caesarean deliveries can also contribute to trauma if injuries to organs in the abdomen and pelvis occur as a result of the extension of the caesarean section incision. This can lead to PPH. We have the fourth T, which is the thrombin. This has to do with coagulation. Coagulopathies can be pre-existing to pregnancy or acquired. This means that the coagulopathies may be present before pregnancy or develop during it. Pre-existing causes that could contribute to PPH include von Willebrand disease or idiopathic thrombocytopenic purpura. Acquired coagulopathies during pregnancy and labor include disseminated intravascular coagulation, which is the DIC, that is secondary to other obstetric emergency such as placental rupture, preeclampsia, amniotic fluid embolism, or sepsis. So, how do we prevent postpartum hemorrhage? First, we check for anemia early in pregnancy, at booking and again around 28 weeks. If a woman's hemoglobin is low, iron tablets or supplement can help boost her levels. Then, we go ahead to the labor. During the third stage, we actively manage it. That means giving heterotonic drugs like synthometrin or synthocinol to help the uterus contract. We also use controlled contraction to deliver the placenta safely. The steps work together to reduce the risk of heavy bleeding after birth. Now we're moving on to the management of PPH. This is an obstetric emergency and it's part of the skill station in your NMC OSCE exam. Before we dive into the steps, you should visit the NMC UK official website to review the midwifery marking criteria. I've attached the link below. Firstly, we recognize the signs by assessing for blood loss. If the estimated blood loss is greater than 500 ml and the uterus feels soft and bulky, not contracting, act immediately. You have to call for help by pulling the emergency buzzer. The first responder would dial 222 and announce a postpartum hemorrhage. You have to request for the multidisciplinary team, which is the senior midwife, the obstetrician, the anesthetist, the pediatrician, and the scribe, which is the subs. You have to position the woman supinely to aid circulation. That is, she has the lie flat with her back and no pillows. You have to prepare for immediate management, reassure her that the team is here to help, and explain each step as you proceed to control the bleeding and stabilize her. We have to place the baby safely in the cot or hand the baby to a trusted relative, ensuring their well-being while you attend to the mother. You have to explain the situation to the woman clearly and gain her consent for the urgent care that will follow. We administer oxygen at 15 liters per minute using a non-rebreather mask to support the mother's breathing. Then we have to look out for the 4 possible causes of the bleeding, which could be torn tissue trauma or thrombin. Firstly, we gently assess the uterine tone and perform a foam massage to help expel clots while encouraging effective contraction. Next, we carefully examine the birth canal for any trauma and if necessary, we repair to prevent further bleeding. After that, we inspect the placenta for completeness, leaving no loops behind. Finally, we monitor the blood's clotting ability. This is to rule out any bleeding disorders. It's important to note that throughout the process, we have to remain calm. Moving ahead, we have to give the proper heterotonics such as the synthometrin, which contains egometrin 500 microgram, with oxytocin 5 IU or 10 IU, according to the clinical situation or the clinical scenario. However, take care to avoid egometrin in women with conditions like severe hypertension, preeclampsia, or eclampsia. Following this, we have to secure intravenous access by inserting 2 large bore cannulas, one in each arm, to collect blood samples for full blood count, liver function test, renal function test, clotting, grouping and cross-matching, and we see more than 4 units of blood. Subsequently, we have to start intravenous fluid replacement using crystalloids, either Hartmann solution or normal saline, administering on initial 1 liter to help restore circulation. Afterwards, we check the vital signs while looking out for the signs of shock. We monitor using the Muse chart every 5 minutes. Then this can be done by either you or one of your teammates. Warning signs include blood pressure less than 100, systolic pulse greater than 100 per minute, capillary refill longer than 2 seconds, and respiratory rate greater than 30 counts per minute. If the bleeding continues, we move to drugs. We can give oxytocin 40 units and 500 ml of normal saline, or we can administer tranexamic acid 1 gram intravenously over 10 minutes under the supervision of an anesthetic. Or, if the bleeding persists, we may use misoprostol 800 to 1000 microgram rectally or carbapenem 250 microgram up to 8 doses, but at the second dose we should start considering other alternative measures. You can use the BNF as a reference for dosage and adapt it to the particular clinical scenario or clinical situation. At this point, your multidisciplinary team would have arrived and can begin to take over some of those interventions. Bimanual compression. This is a whole procedure which I'll make another video on, but in this video I'm just going to summarize it. For bimanual compression, the midwife places one hand on the abdomen and the other hand inside the vagina, then compresses the uterus between the two hands. This technique causes the uterus to contract, treats autonomy, and assists with expulsion of retained placenta or clot. When bimanual compression fails to control the bleeding, we move into other alternative measures. These include inserting a uterine balloon tamponade to apply internal pressure and stop the hemorrhage. If bleeding persists, surgical options may be considered. A beeline suture can be applied to compress the uterus and reduce blood loss. Undiagnosed tears or laceration should be identified and repaired under anesthesia. As a final result, if all other measures fail, a hysterectomy may be performed to save the woman's life. Following surgical management of postpartum hemorrhage and resuscitation, post-operative care is vital. The woman should be transferred to a high-dependency unit for ongoing monitoring. Observations must be carried out every 5 minutes, and a final estimated blood loss and a full blood count should be documented after 6 hours. In addition to physical care, encourage early bonding with the baby and support with feeding as appropriate should she want to. Please remember the 3 Ds and the 1P. Debrief the woman and her family and her relative about what happened. Also debrief your team as well. Document the events clearly and complete a day-text for incident reporting and fill out the proforma. This ensures safe follow-up care, emotional support, and learning for the team after a major obstetric emergency. Just before the end of the video, I would like to give a reminder, which could be seen as the EDTA. E stands for examine, D for drugs, T for treatment, and A for aftercare. We go on to the examine, where we grouped it into recognizing the signs, calling for help, the position, the vital signs, and assessing the 4 T's. We move over to the drugs,
where we have the uterotonics, the IV fluids, and the bleeding control, which is the medications we can use to control the bleeding. Then we go on to the treatment, whereby we have IV assess, administering oxygen, bimanual compression, and alternative measures which involves the theater. Moving on to the aftercare, we have the high dependency unit, which is the HDU. We have the observations, the 3Ds and 1P, the bonding, and the feeding. At this point, we've come to the end of the video. Thank you for watching. And don't forget to like and subscribe for more videos like this.